Children with cerebral palsy are born with weak muscles of the neck, chest, and abdomen, sometimes so severe that they cannot lift their heads when lying in a prone position. Within the first year, most of the children with cerebral palsy gain neck strength, but their chest and abdomen remains weak for years to come. These children have difficulties in attaining and maintaining anti-gravity postures and performing many motor activities. Please join me in analyzing how healthy people execute most motor activities. The following steps appear to exist in all movement. We first stabilize the trunk of the body by simultaneously contracting muscles of the neck, chest, back and abdomen. This contraction creates a stable anchor for us. Only after our body is safely stabilized in this manner do we perform various motor activities using our upper and or lower extremities or make postural changes of various types. From this analysis, it appears that proximal stabilization is always the first step in every motor activity, and proximal instability appears to be among the earliest physical deficiencies of cerebral palsy, since most children with cerebral palsy are unable to stabilize their chest and abdomen due to muscle weakness. How does proximal stabilization therapy, PST, help these children? We support the chest and abdomen of the CP child with an external muscle-like device which is called as trunk support. It is exhibited here. By properly using this support, children's abilities are enhanced. This concept was first presented by Mr. Damodar G. Kamath at a conference in Montreal in 1988. Ever since, the author has been using PST program for children under his care and collecting data about the outcome of the program. He had also conducted a research study in 1991 at KMC Hospital, Manipal, India. During the study, he documented improvement of 10 CP children's range of movement of upper and lower extremity joints, videotaped their progress. The results were all indicative that the PST program helped them. This was presented at the Retina Conference of 1995. To make the program popular, the author has also presented 9 papers at various conferences in Asia, Europe, and North America, which includes a presentation at the annual meeting of the American Academy of Cerebral Palsy and Developmental Medicine at Seattle. Here are some of the successful children. 1-year-old Kulsum, who is right hemiplegic, and Rakshita, an 8-year-old quadriplegic. Please watch the right hand of Kulsum and the left hand of Rakshita immediately on wearing the brace. What's it about? In the year 2013, among the children treated by the author, 20 children had cerebral palsy. 10 were quadriplegic between the ages of 14 months to 5 years. 4 of them stood up and started walking right away after wearing the trunk support. The remaining 6 walked within 1 month. Each one of them needed minimal support from behind by the parent. One mild quadriplegic, 2.5-year-old boy became totally self-dependent. He wears the trunk support and does everything like a normal child. Among the remaining 3 were right hemiplegic between the ages 1 year and 8 months to 3 years and 3 months. Within 2 months of PST, they used the right hand. Similarly, 3 left hemiplegic between the ages of 2 years and 3 years and a month also achieved their left hand function in 2 months. Also, 2 very severely involved children who were unable to do anything started rolling within a few days of PST. Bobak's neurodevelopmental treatment, NDT, has been in practice for many years now, and its results are all around us. Regardless of how much NDT a CP child receives during childhood, most CP children grow up as handicapped adults. The NDT program, by making the CP children walk with the help of walkers and crutches, often diminishes their fine motor skills, whereas CST gives the children an opportunity to develop them. With PST, about 2/3 of spastic children will have enhanced abilities if they begin to use the program before the age of 3 years and 6 months. It takes only 18 months to achieve maximum motor ability. Some children become totally independent like normal children. The remaining one-third are children who are slow or have additional problems such as visual or auditory deficit. They take a longer time to improve. The profoundly retarded may not benefit by PST. Giving CP children an opportunity to master self-care with improved fine motor skills has certainly gone a long way in boosting their morale and self-confidence. Despite such consistently good results the last 30 years and the author's concerted efforts to make the program popular, PFT, a helpful program, remains unknown even today. Why? The conferences where he presented the paper do not seem to have made much effort to pass on this helpful program to help the local cerebral palsy children, although the conferences were organized to collect and implement new technology. Therapists who treat CP children do not necessarily have access to conference proceedings. Their main source of knowledge is from expensive courses they took from the renowned international organizations which teach only Bobat therapy, claimed to be the only treatment for CP children.